Good morning, good afternoon, good evening, wherever you are. Welcome to our SRH webinar on self-care interventions on SRH. Today we have two distinguished speakers on self-care interventions. This is kind of a reintroduction to the previous presentation based on popular demand from our last webinar. So today we have Dr. SPIRHR, who is an assistant professor of obstetrics and gynecology, and she is also a family planning fellow and family planning and RH fellow at St. Paul Hospital Medical College. We also have another distinguished speaker, Dr. Nazanet, who has a PhD in public health with reproductive health specialty. She has more than 9 years of work experience in reproductive health program implementation in research institutions, and she has contributed different research outputs on as an individual consultant for the health sector with special focus on reproductive health, adolescent health, and sexual and gender-based violence. She's now working at the Ministry of Health as maternal health expert. We are very delighted to have both the speakers with us today. First, we will have the presentation by Dr. Makdes, followed by Dr. Nazanet. So you have the floor. Thank you.
Hello, everyone. Today, I'm going to discuss self-care interventions in sexual and reproductive health, focusing on self-management of medical abortion and self-administration of injectable contraception. I'm going to talk about an overview of self-care interventions for health and well-being, then take a bit of deep dive into self-management of medical abortion and self-administration of injectable contraception, and finally self-care intervention regarding sexual and reproductive health in Ethiopia. Self-care is now a very acquainted word in daily life. WHO defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, and maintain health, to cope with illness and disability with or without the support of a health worker. And when we say self-care interventions, these are tools that support self-care. These include evidence-based, high-quality drugs, devices, diagnostics, and/or digital interventions that can be provided fully or partially outside formal health services and be used with or without a health worker. So why do we need these self-care interventions for our health and well-being? Currently, 3.6 billion people, that means half of the world, lack access to essential health services. As self-care is considered as primary health care, it advances this agenda. The second is it increases agency, autonomy, and empowerment of individuals and communities regarding their health and well-being. WHO recommends self-care intervention for every country and economic setting. Subsequently, this will strengthen national institutions with efficient use of domestic resources for health as a critical path to reaching universal healthcare coverage, promoting health, keeping the world safe, and serving the vulnerable. By implementing self-care strategies, there are a range of outcomes which will get improved. The first is reduction of health disparities and cost, and also increment of health coverage, access, equity, and quality of care. This also improves health, human rights, and social outcomes, and efficient use of resources. These self-care interventions, they are linked to our everyday life and also to the health system as well. So they are like a bridge between our life and the health system in place. So the first one is self-management. When we say self-management, it includes several things. Some of the examples are like, say, self-medication. This might be taking over-the-counter drugs or prescribed drugs accordingly. Self-treatment, self-examination, like doing breast examination, or giving attention to oneself. Self-injection, like injection of insulin. The next one is self-testing, then self-sampling, self-screening like home pregnancy test, HCG level self-screening for HIV, self-sample collection for HPV testing. This all considered as self-testing. The last one is self-awareness. So self-awareness is very important. So this is self-help, self-education, self-regulation, self-efficiency, and self-determination. As self-awareness is, as I said earlier, it's very important as this leads to early health-seeking behavior, or know when to visit health sectors and make us mindful of different illnesses. This pyramid shows a large number of community need mostly like primary self-care, then where autonomy is high and the cost is really low, and still self-care continues throughout the healthcare pyramid, even in those patients who are admitted for specialized care. So self-care doesn't stop at home or at workplace or at school. So it goes a long way up to health facilities or specialized setups. Still, there are some health system challenges for self-care. These challenges might be different from setup to setup, country to country, individual to individual, because self-care is individual dependent. So these challenges might be different for every kind of setup. So the first one is low level of health literacy and lack of accurate information, where kind of like this explains like where can a person get reliable information about self-care, or how one person can interpret that information or knowledge, or how one uses that information as intended. So low level of health literacy and lack of accurate information is one of the challenges to self-care. The second one is accessibility. So access might be affected by regulations, infrastructure, setup. So for someone who doesn't have a smartphone or a digital technology, talking about self-care, which is used, or like the intervention is on software or a digital platform, might not make sense. So access is another thing. Then the third one is availability. So there should, this talks about like when the challenge of commodities needed for self-care, and then validity. So those self-care interventions should be tested and validated so that they will be safe and also they will be uniform. Then acceptance of the result by the formal health system. So this is about like the trust of the formal health system on the individual to take care of like their service. Economical interest, this might compete with paid services, then also it will create a change in power dynamics. So these are some of the challenges of self-care. But self-care also comes with opportunities. One of the prospects is having a living guideline, which is launched by World Trade Organization in 2022. And the other is the use of digital tools for health intervention, and finally having a previous experience. So COVID is a recent event where we learn about like prevention, picking early signs, protecting our family and others, taking care of ourselves if we got infected, and a lot of self-education and information exchange. So this previous experience in the pandemic is one of the opportunities, or one of like that's been a learning opportunity for self-care. The other opportunity for self-care is this guidance. Self-care can be tailored to any kind of society and population, and not only digital tools, but several kind of like paper-based tools or any other tools can be developed based on the society or the community that we serve. The mode of access for self-care are multiple, starting from home and workplace or work-based care to basically anywhere through any situations, including humanitarian crisis. So in the school, pharmacy, in like health facilities. So as I've said earlier, self-care can be accessed anywhere. These are some of the examples of self-care interventions in sexual and reproductive health. The one which I have highlighted are the one which I'm going to discuss in detail. So in family planning, like self-provision of contraception pills, self-administration of injectable contraception, self-management of medical abortion, HPV self-sampling or sample collection, self-sampling for sexual transmission, HIV testing are some of the examples for sexual and reproductive health. I will start with self-management of medical abortion. Abortion is, as you know, it's a common health intervention. It is safe when carried out using a method recommended by WHO, appropriate to the pregnancy duration and by someone with the necessary skills. Around 73 million induced abortion takes place worldwide each year, and 6 out of 10 all unintended pregnancies ended in an induced abortion. Unsafe abortion is a leading but preventable cause of maternal death and morbidities. It can lead to physical and mental health complications and social and financial burden for a woman, communities, and health system. And 97% of all unsafe abortions occur in developing countries. So self-care of or self-management of abortion will increase access and autonomy for the woman. So when we say self-management of abortion, it's where the whole or part of the abortion process is managed by the woman. In self-management of abortion, it is the woman who drives the process, deciding which aspects of the abortion care will be self-managed and which aspects will be supported or provided by a trained health worker or in a health care facility. Self-management of abortion is for gestational age less than 12 weeks of gestation. So there are 3 components of self-management of medical abortion. The first one is self-assessment of eligibility. The second one is self-administration of abortion medicines and management of the abortion process outside of healthcare facility without the direct supervision of a trained health worker. And the final one is self-assessment of the success of the abortion. Self-management of medical abortion is one of the safe and effective options of abortion care. It's evidence-based, acceptable, cost-effective, and as I've said, it improves autonomy. What is needed for self-management abortion is the first and the most important thing is access to accurate information. So this information will be from, it can be from any health worker, health facility, or any platform, but it should be, as I've said, reliable one, accurate one, and validated one. So it will tell the woman or it will inform the woman about the process. It will help her to decide, like to make informed decision, other options other than termination of pregnancy, self-assessment of like gestational age, using last normal menstrual period or tools, or using pregnancy test, what are the danger signs, side effects, complications, and we might have like different protocols for those or checklist. So that's the first one, access to accurate information. The second one is medicines. So where to get them, or what kind or type of medications that include adequate pain management of pain medications, and the whole cost burden should not be transferred to the woman in self-care. So this should be also put like into consideration. And the final one is support of trained health worker and access to healthcare facilities and referral services if they need or the woman needed or desired. So as I said earlier, we have 3 components of self-management of abortion. The first step is self-assessment of eligibility. Here, the purpose is to determine the pregnancy duration and rule out contraindications. So, as I've said earlier, this can be done by using last normal menstrual period alone or in combination with other tools. It can be done through telemedicine, and it can be done with digital or paper aids, or it can be done also with a health worker. The second one is self-administration of the medicines and the whole abortion process. So we have 2 options for self-management of medical abortion. The first one is a combination of mifepristol and misoprostol, where the woman will take 100 milligrams of mifepristol orally on the first day, and should wait 1 to 2 days, and took 800 micrograms of misoprostol administered locally, sublingually, or vaginally after like 1 to 2 days. And the next option is taking only misoprostol, that's 800 micrograms misoprostol administered locally, sublingually, or vaginally. Since mifepristol is available in our country, for those women we managed we give home-based care, like up to 9 weeks of gestation according to our national guideline. We usually use the first one, like giving mifepristol, and then followed by misoprostol. Finally, self-assessment of success of the abortion. So this can be symptom-based, or using pregnancy tests, or can be assisted by a health worker, or if the woman wants it, then she can go to a facility. So again, this depends on different protocols and different laws and regulations. So self-assessment of success of abortion is the final step. But like through all these steps, as I've said, if the setup allows it, all the 3 components can be done by the woman with a good support and information, or the part of it can be done by the woman. And now we are going to see some overview of self-injectable contraception. Family planning or contraception is a life-saving intervention with a well-recognized social and economic benefits. Injectable contraception being the widely used method in our country and one of the very effective methods in preventing pregnancy. Increasing access, autonomy, and availability is crucial, and it is an obvious step forward. WHO recommends that self-administered injectable contraceptions like Depo medroxyprogesterone acetate in subcutaneous form should be made available as an additional approach to deliver injectable contraceptions for individuals of reproductive age. Evidence found significantly higher rates of contraceptive continuation with self-administration as compared with administered by health worker, and safety and effectiveness is comparable. Either the woman take the injectable contraception at the health facility, or she self-administered the injectable contraception. The same is true for having like self-administered injectable contraception. There are some things which are important and needed. The first one is eligibility. The woman needs to be medically eligible to use injectable contraception, and it should be the choice of her contraception. We go through all what we do when we provide basic contraception. So contraception counseling and also the other steps. And provision of the first dose are done usually by the healthcare provider. So that first contact also will make us will create that opportunity to give information in training prior to injecting or for the first time. So then information in training prior to self-injecting for the first time, we will educate the woman how to store and dispose the device, explanation and demonstration of how to inject using a model, different like national resource models can be used, and the woman self-injecting while being observed by the health worker, and information where to get more injection devices will be given as an information. And finally, access to health worker in the event of questions, problems, or a desire to switch methods. And it's also important to incorporate self-administration of the MPA into family planning services so that it can be monitored for uptake, use as intended, and cost incurred by users, and to identify any related social harm. On the first visit, as I have said in the previous slide, we teach the woman how to self-inject using a model. Here I'm going to show you a short video on self-administration of subcutaneous Depo-Provera.
SRHR Press is an injectable contraceptive that works for 3 months that women can use in their own homes. It's an easy process. Make sure the pouch is undamaged, not expired, and at room temperature. Choose a spot you want to inject, your stomach or thigh, and avoid the navel and bony areas. Open the SRHR Press pouch. Make sure the needle has a shield and there's a gap between it and the port. If you don't see the gap, or if there's damage, throw it away and use a new one. Hold the device by the port and shake it for 30 seconds to activate. The medicine should be evenly white. If not, discard it and use a new one. Now you're ready for the injection. Wash your hands and the injection site and let them air dry. Hold the port up with one hand, then push the needle shield into the port until you hear a popping noise, like a pen click. Remove the shield from the needle. Pinch the area you want to inject with one hand, and with the other, put the needle in until the port touches the skin. Slowly squeeze the reservoir for 7 seconds, then pull the needle out. Throw away the used injector as your health worker instructed. After your injection, you are protected against pregnancy for 3 months. For more details, check out our website.
As you can see in the video, it's straightforward and not a complicated process. And finally, we discuss where the client can safely store the devices for many months. They should be kept out of reach of children and animals, and they should be kept in moderate temperature, that is in room temperature, out of direct sunlight, or in a refrigerator. So they should not be, that means, refrigerated. And then we discuss how the client can dispose the device in a container that has lid and cannot be punctured, or which can be kept away from children. So local programs should decide how to help the woman to dispose of the needle safely. So this will be discussed in detail, but Ethiopia is like in the context, when we see in the context of self-care interventions, what I know is we are on the final stage of launching a national guideline on self-care intervention. So in conclusion, self-care interventions are among the most promising and exciting approach to improve health and well-being, both from a health system perspective and for the users of the interventions. Self-care interventions have the potential to increase choice and autonomy when they are accessible, acceptable, and affordable. Risk and benefits should be tailored for different population groups and health systems through appropriate normative guidance, like what we are doing currently. The safe and supportive enabling environment and sustainable implementation of programs is also important. Thank you very much for your attention. These are the references for the webinar presentation.
Well, good afternoon, everyone. Now I'm going to talk about self-care interventions in Ethiopia. This is my outline. As usual, I will start by defining what self-care is, and then we'll go to the rationale why we need self-care interventions. I will briefly talk about the policy environment in Ethiopia regarding self-care interventions and what are the selected self-care interventions in Ethiopia and the status of the self-care interventions, the implementation status, and finally, I will going to conclude. So to start with the definition, self-care is the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disabilities, with or without the support of healthcare providers. This is a standard definition from the World Health Organization. And as you can see, this self-care is done by individuals, by families, and communities. And the whole aim is to promote health, to prevent disease, maintain health, and cope with illness and disabilities. And also it is done with or without the support of healthcare providers. And this is a standard definition from the World Health Organization. We also adapted this definition in our national guideline. And before going to the scope, I want to say something on the scope, on the interaction, on the aim of the self-care interventions, because there are misconceptions, and some of them they interpret as it's a replacement of a direct interaction with the health system, but the aim is just to complement the direct interaction between individuals and the health system. It's not actually a complete replacement of the direct interaction between individuals or families with the health system, but it's going to complement this interaction. In saying this, when we see the scope as it is included in the definition, the first is just to promote health and to prevent disease and to control disease. And it also includes self-medication, self-sampling, and self-testing. And it also includes providing care to dependent persons like children and those who are in the geriatrics age group. And it also extends to seeking hospital care or specialist care if it's necessary. And finally, the rehabilitation, including the palliative care. So these are the scope of self-care intervention. So the rationale why we need self-care, as most of you know, just as a provider to bring the intended outcome while we are providing services, the whole health system from top to down should function properly. However, these days, the health systems, they are strained by increasing demand for responding against public health emergencies. And as most of us remember, COVID-19 is one of the recent experience. And when health systems are strained in responding against these public health emergencies, there is definitely a compromisation of access to essential health services because they are strained while providing or responding for these public health emergencies. At the same time, they are expected to provide basic health services for the community. So in these situations, access to essential health services compromised definitely. So in these situations, self-care will come in the top. And when we are considering self-care, as I tried to say in the first 2-3 slides, when we are considering self-care, the families, the individuals, they are not expected to have a contact with the healthcare system for each and every complaint. So this is one of the rationale for self-care interventions. The other one is the second 2, 3, 4 slides. They are taken from the report of the United Nations in 2019. That report actually highlights globally by 2030, around 80 million health worker shortages anticipated by 2030 globally. This is a huge number. And again, in 2019, around 400 million people worldwide lack access to the most essential health services. And this is again a huge number. And also in 2019, around 130 million people need a humanitarian assistance, right? So this is actually a challenge for the health system. And when we see again the health systems in low and middle income countries, it's also a double burden. And at the same time, the world is committed to achieve universal health coverage by 2030. And so achieving this universal health coverage with all those challenges, it needs actually, it's a clear indication that there need to be innovative approach included in the health system. So self-care is included as one of the innovative approaches just to have a solution for such challenges globally and nationally. So this is one of the rationale. The other one is the humanitarian settings, and we have also recent experience. Our country, as you know, was in a triple burden: the pandemic, the COVID-19 pandemic, the conflict, and the drought. And in such situations, again, the health systems are strained because, for example, if we take the crisis settings, the health system by itself or the healthcare facilities by themselves could be affected by the crisis. And at the same time, they are also expected to provide service for the population, for the internally displaced people and the like. So when we take, for example, like a situation in our country, having a response plan and making the facilities restore the basic services, it could not be done actually in a short period of time. So in that case, self-care again could be one of the options to have the services distant from the healthcare facilities. And the last one could be cost. When we say cost, it's calculated, for example, from the demand and the supply perspective. So both will give us the whole cost for the healthcare service. So when we consider self-care, for example, we'll have a transportation cost. We'll have from the patient side. We'll have also resource healthcare providers time and the like from the supplier side. So from this perspective, we will have also a reduced cost while providing healthcare interventions to the community. So these are some of the rationale why we need self-care globally and nationally. And this is a framework from WHO. A framework for self-care interventions. It has 4 key areas. The first one is key principles regard to self-care and the places where we can access self-care, the enabling environment is accountability. And when we say key principles, it includes like human rights, gender equality, ethics, life course approach, and holistic service. And it's actually clear every human being has to get the services they need, the healthcare service, and we'll have gender equality in between. And it should be approached in a life course, in a life course starting from pregnancy up to adulthood, and it should be also holistic. So these are the key principles. The other is the places where we can access self-care. We can have caregivers for self-care. We can access it from pharmacies, like by taking self-medications and the like, and we can access it from health services. And digital technologies and platforms are also there For example, in our cases, like for the adolescent and youth population, it's one of the potential platform, and we can access it again from the community, from the traditional and socio-cultural practices, and also from home. So these are the potential places where we can access self-care. The other one is the enabling environment. So this enabling environment is actually different for different contexts. However, there are recommendations from WHO, like the community security could be one of the enabling environment. In our country, for example, we can take the community security for life-saving commodities, because the government is committed to provide them yearly, because we are doing forecasts in the procurement for this life-saving commodities, and we can say we can consider it as one of the enabling environments. The other one, the supportive policies, the economic environment, the information, right, the health literacy education. All these are the trained health workforce. All these are considered as enabling environment, right? And in our country, for example, in our context, we can have a trained health workers. We can take, we'll have the health extension program. We can have community level conversations with this health extension program, and so we can have different enabling environments which are context based for self-care interventions. The other one, the accountability. This framework clearly identified that everyone is accountable for self-care, because the health sector itself, the donor, the implementer, the government, individual, the social, there is a social accountability in the private health sector. All of the stakeholders are accountable for this, for the implementation of these self-care interventions. So this is a framework from WHO. And coming to the policy environment in Ethiopia for self-care interventions. Actually, before going to the details of the policy environment, I want to highlight that self-care was practiced in Ethiopia because, as you all know, this self-care is practiced by our mothers, grandmothers in the community, because they treat like some diseases at home, right? For example, you can take common cold, sore throat, and the like. They treat diseases at home, and if they need actually, if they get worsened, they will visit health institutions for higher level care. So we can say that we have the foundation for self-care in Ethiopia. But after the World Health Organization provided a global recommendation for this self-care, we have also considered this self-care in some of the relevant policy documents, like the Health Sector Transformation Plan. We have self-care in the Health Sector Transformation Plan under Strategic Theme 2 in Excellence in Quality Improvement and Assurance, where this self-care itself, the patient and population engagement, is recognized as a heart of all of the policy and strategies in Ethiopia. And it's a broader, as you know, it's a broader plan for the sector, and self-care is included in HSTP 2, which currently under implementation. The other one, as you know, from this broad plan, we'll have program-specific strategies. We have the reproductive health strategy, which is currently implemented starting from 2021 up to 2025. And self-care is clearly indicated here as very importantly, two important major initiatives are included. For example, the first one is advocacy, as you all know. When we introduce new interventions, we first advocate for it, right? So the advocacy will start from the higher officials, including the parliamentarians, higher officials of the Ministry of Health, the relevant sector government offices, and non-governmental organizations actually, and from top to down the health system, including the community and the general public. So advocacy for self-care is one of the major initiatives in reproductive health strategy. And we have also another major strategic initiative which provides selective self-care interventions like HPV self-sampling, HIV testing, breast self-examination, and the like. So these are the two most important initiatives that are included in the reproductive health strategy, which is under implementation currently. And again, we have again program-specific strategies. So from these program-specific strategies, we have program-specific guidelines to guide the implementation of specific programs. So for that, we have developed the National Reproductive, Maternal, Newborn, Child, Adolescent, Youth Health, and including nutrition self-care guideline. Actually, the development is already done, and it's on the way of endorsement. And I want to emphasize that from the definition, if you remember, this self-care could be done with or without the support of healthcare providers. So in our national guideline, we want to emphasize provider-supported self-care, where providers are expected to counsel the mother, and if, for example, if they have to check whether the intended outcome is achieved or not. So our national self-care guideline will based on provider-supported self-care interventions. The other one, the communication guide. This national self-care guideline also emphasizes the importance of social behavioral change communication. So because of that, we developed our already the communication guide, and it's in a good draft now, and we have given it to the National Communication Advisory Council of the Ministry for review, and it's under development. And here is the front page of the National RMACAOH, including Nutrition Self-Care Intervention Guideline, and it's under review by the program state minister and his advisors, and probably it will be endorsed in the next 10 to 15 days. So the other is self-care interventions in Ethiopia. So these are the selected self-care interventions which are included in the guideline. And the first one is self-care interventions for maternal health. So I will going to highlight some of the interventions. That doesn't mean all of the interventions are included here, but I want to highlight some of the interventions. For example, for maternal health, we'll have self-care interventions during pregnancy, labor, and childbirth in the postnatal period. And we have included like heartburn, how to manage heartburn, low back pain, nausea, and vomiting during pregnancy. In the postnatal period, the importance of early ambulation, the care for wounds, for example, if it's operative delivery and the like. We have included it in the maternal section. The other one is self-care for medical abortion. It's also included in the maternal section of the guideline. And hopefully, Dr. Matlas will say more on this. And the other one is on family planning. Again, family planning, we have to try to include over-the-counter oral contraceptive pills, emergency contraceptives, and other contraceptive options, which are already on the National Family Planning Guideline, and self-pregnancy test, which is actually important to start family planning service. If it's negative, should start a family planning service, or if this is positive, again, should initiate early antenatal care as per the guidelines, the National Antenatal Care Guideline. So these are some of the initiatives under family planning, and I have highlighted this maternal health in family planning because it's the focus area of our today's webinar. The adolescent youth health, it is more built on improving SRHR information and life skill information through digital technology, because most of the adolescents and youth health, they have more of their time on this digital world. So we have to improve this SRH information in life skills through digital technology. And again, these self-care interventions are also targeted this adolescent and youth group. And so health education and information on self-care interventions is one of the priority area of self-care interventions themselves on this adolescent and youth health age group. The other one is menstrual hygiene management, which is one of the gender-sensitive response in this age group. And coming to the neonatal and child health, these are also some of the initiatives like promoting positive maternal or caregivers' mental health, because it has its own direct impact on child development, and prevention of common childhood illnesses and treating them at home is also one of the initiatives, and promoting ECD, which is an important initiative. Early childhood development is also included here, and children's safety and security, ensuring that their playground as it's safe and secure is also included here as one of the self-care interventions in the neonatal and child health program. The other one in API service, it's more on vaccine preventable diseases and providing information on the national immunization schedule, and very importantly, self-detection of notification and management and referral of this adverse effects following immunization is the self-care interventions that are included in the API service. The other one, the nutrition service, will have nutritional assessment, the habit of healthy eating and physical activity, and the prevention of malnutrition, especially during pregnancy, are emphasized in the nutrition service. And coming to the PMCT, we have HIV self-test and we have HPV self-sampling. And these are the highlights of some of the RMNCH including nutrition interventions that are included in the guideline. So saying this, again, we'll have a detailed implementation considerations, because it's actually the whole thing is to integrate self-care in the existing services, but we have to have implementation considerations for these all initiatives. So in the guideline, actually, each of the initiatives has got its own implementation approach, but here I want to give a highlight of some of the general considerations in the implementation approach of self-care interventions. For example, the first one is health education. Whenever individuals or families or the community have a contact with healthcare providers or with the health system, we'll have a health education. This is one of the implementation approach. The other one, the digital technology. This focuses more on the adolescent and youth health. Actually, it also applies for the rest of the population group, but we'll build more on the adolescent and youth group. And we'll have mobile applications, and we'll have health message, health education through these mobile applications. And again, we'll have TV and radio spots and community conversations using our health extension program. We'll have community conversations and TV or radio spots, which will be done using different local languages. And the other one, the social behavioral change communication for healthcare providers, because we want to build on this, because we need a special counseling actually, because for example, our clients, our patients will not understand, because usually we are not dealing with literate population, right? So in this case, we have to have a clear and direct communication with the clients, the patients. So we need to build on this social behavioral change communication for healthcare providers. And this is one of the implementation approaches. The other one is training for healthcare providers. And also availing drugs and kits is also one of the implementation consideration. We'll have text message and free call centers where the community can call and get health information, health educations, and also how to get the service, where to get the service, and the like. And the other one, again, for the adolescent age group, we'll have mini media like to build on the life course, the life skill approach, and the like. And we'll have recorded health message for community level conversations, and leaflets and brochures to be distributed using different platforms, which could be developed in different local languages. So these are some of the implementation considerations. As I try to say, each of the initiatives has got their own implementation approach, and but this one is a general consideration. So coming to the status update, where we are on implementing self-care interventions, like I said, the guideline is on the way of endorsement, and hopefully we'll have it in the next few days or few weeks. And again, we have consultative workshops with stakeholders like regional health bureaus, development partners, implementing partners, donors, and every stakeholder. We have repeated consultative workshops. We have also experience sharing this from the WHO and also we have a communication guide which is under development. This is one of the status updates I want to give. The other one is we're piloting the self-care interventions in 4 regions, where we provided training for selected healthcare providers. And we have 4 learning districts, which is in Addis. There are 2 health centers from Addis, 2 health centers from Amhara region, 2 from Somali, and 2 from Oromia. And we have selected these regions intentionally because we have to get learnings from different contexts. Like we can have the pastoralist context from Somalia. We have the urban context from Addis, and we have the agrarian context from Amhara and Oromia. And we'll have the whole picture of learning from these 4 regions. And for this, we have provided training for selected health workers, as I said, and it's under implementation. The other one is we have established a national self-care network nationally, where 10 of the development partners are members. And we hope we'll have also good advancements of the self-care intervention using this self-care network, national self-care network. So these are some of the status updates. And coming to the conclusion, self-care interventions, they are among the promising interventions to improve health, and we can say this from the perspective of the health system itself in the user's perspective. For the reasons I tried to say earlier, it's one of the promising initiatives. And in the second bullet, I want to highlight, this is the text from the WHO guideline, and it says, in implementing these globally relevant recommendations, WHO regional countries can adapt them to the local context, in taking into account the economic conditions in the existing health services and healthcare facilities, which actually clearly indicated the importance of adapting these self-care interventions into local context and considering the existing health services and the healthcare facilities. So this is what we have done nationally, and we can say that we have a supportive we have a supportive policy environment in Ethiopia to implement culturally sensitive self-care interventions. And as I said earlier, we are piloting, or we have already 4 learning districts where this self-care intervention is being piloted. And based on the results, we will scale up to a larger geographic area in the future. So this all, thank you.
Thank you, Dr. Mekres and Dr. Nazanet. I think it's now time for Q&A. I see we have a few questions. Yes, there are some questions that are answered live. Before we circle back to those, let's see some of the questions that are not yet answered. So one of the question is, how is the experience of self-medication abortion in our setting? So, Dr. Mekres, may I forward this question to you?
Thank you, Dr. Farid, for the question. So, still our national guideline doesn't incorporate self-management of abortion. We have abortion care at home until 9 weeks of gestation. So, to provide like legal and safe abortion, we follow the national guideline that is providing, assessing eligibility and providing the first medication, that's mifepristone at health facility, subsequently followed by the misoprostol at home, and for the woman to come anytime if there is any danger signs, or if there is a need for contraception, or if there is failure of the medical abortion. So
yeah,
can add on that.
Yeah, thank you very much. I think this has been a practice for many healthcare facilities, but there is still a lack of documented evidence as to the outcome and the values and prevalences of women who have undergone self-medication abortion. So yes, as you said, in most places there is the assessment of eligibilities done at the healthcare facilities, that the subsequent self-care interventions are not well documented. So it's probably one of the areas where evidence generation and piloting can help in terms of making higher level recommendations. So the other question, again, before I proceed to that, just to all the participants, apologies for the frequent internet disconnections. We're having a terrible weather here, so apologies. And okay, so the second question is, how can we integrate self-care intervention within the existing health structure? Is there a need for like having a structure basically at the primary healthcare units? So probably I'll forward this to Dr. Nazanet.
Okay, thank you, Dr. Farid. The National Self-Care Guideline is actually have its own implementation considerations, right? So we are not considering this self-care intervention as a standalone to be implemented in a standalone structure, but we have a plan to integrate it in the existing health system. But we need to have some implementation considerations because, as you know, it's a new initiative. So we have to have implementation considerations that are actually complements the existing health system. So this is what we have in the guideline.
Okay, thank you, Dr. Nazanet. So there is another question on initiation of medical abortion by the as a form of self-care, and especially on eligibility assessment, particularly on gestational age. So where probably I'll direct this to Dr. Mekres as to the evidences where women can actually self-assess gestational age and eligibility.
I think I can answer this question along with Professor Delayo's question. The evidence are more to less than 20 weeks of gestation, but on the WHO guideline of self-care interventions for health and well-being in 2022. They have looked into like 16 studies, and in those studies it shows that self-assessment of eligibility is safe and credible. But it might be what we need to understand about self-care is it's different for different individuals. So it is different for different setups, and it's also different in different laws and policies like regulations. So that should be always in our mind. So first, like before we go to like ask the woman to assess herself for gestational age or eligibility, we need to go some road to reach there, like on regulations, laws, policies, piloting, even as Dr. Farid said earlier, reevaluating what we have until now, like for up to 9 weeks. How are the women being managed at home are taking that, like, so we need to have local evidences so that we know what will work for our country and for the women in Ethiopia. Thank you.
Yeah, thank you very much, Dr. Muklas. Those studies that you mentioned have used different modalities in terms of how women can actually assess their self-assessment of gestational age. These include mobile applications, pregnancy wheels, checklists. So in those studies, those were like a pilot where women were actually given those instructions, and they try to self-assess gestational age and eligibility. So I think it's the right time where we can, make our own pilot and say, okay, this is what would work for the Ethiopian setting and what will not work for the Ethiopian setting. So down the road, this may come as a plausible solution. I think the idea of self-care. Yes, Nazanet, please go ahead.
Just to add some point on this, we have as I said earlier, we have 4 learning districts where we pilot this self-care intervention. And from the start, we have to have implementation research from the start, but because of budget limitations, we couldn't make it. But we'll have a formal documentation at the end of the pilot, and we'll have a formal report for that. But regarding the eligibility on abortion care, the self-care guideline clearly puts that this has to be, the eligibility has to be confirmed from the healthcare provider, because in our setup, as you know, the last normal menstrual period is not usually remembered by the mother. So we clearly put in the guidelines that the eligibility should be first checked at health institutions. Just to add this.
Yep. Thank you for the clarification. Yes, I think the upcoming guideline will be more, it will give more clarity on which aspect of self-care can actually be used for medical abortion. I think the idea of self-care should be taken into consideration of what has been done in the medical field in general, in reproductive health in particular. So the idea of self-care has been practiced for a very long time in terms of people actually taking care of their own medications. One typical example is how people used to treat themselves for diabetes. So, I mean, we teach people how to do self-injection of insulin, right? Nobody comes for insulin injection to a healthcare facility, but that doesn't happen overnight. People were given instructions on how to inject themselves, how to identify symptoms of hypoglycemia, and the medical field is very much comfortable in terms of, shifting that task to the actual individuals. So that idea of, bringing those individuals into their own healthcare rather than just a mere recipient of healthcare is very important. Having said that, let's address also a few more questions before we run out of time. So one important and very interesting question comes, how do you see the impact of self-management of abortion regarding unsafe sexual practice and more reluctance? Is there any evidence May I forward this one to Dr. Makdas?
And can you clarify that more?
So I think would having the ability to self-manage medical abortion, would it increase the risk of unsafe sexual practices and being more reluctant? Is there
More
any
reluctant on like practicing
sexual
safe sex?
practices? Yes, that's my assumption because with the notion of the question.
Okay.
Yeah, is there any evidence that you came across?
As far as my knowledge, I don't have evidence for that. But just think about like family planning or contraception or any other health education and promotion and the like. So this should not make someone more reluctant or to have unprotected sexual, like unsafe sex or practice unsafe sex. That's my own opinion, but I don't have like good enough evidence, like if self-management of abortion is strongly or significantly associated with unsafe sex or being, as it's been said, reluctant.
Maybe to complement some on what Dr. Makdas said.
Please go ahead, Nizana.
Okay. So here the importance of social behavioral communication comes because as to our guideline, this self-care interventions should be communicated clearly that the interventions should not go beyond the technical guidelines. For example, for abortion, we have the technical and procedural guideline. So we didn't make any addition on the listed, for example, the 5 listed criteria. When we are introducing self-care, we have to go with those 5 listed criteria. So the importance of social behavioral change communication will be very important here. So we have to clearly communicate that the regulations, the policies will go with the self-care interventions. And I have also the same idea with Dr. Makdas that this will not have a different impact on the health system.
Yeah, thank you very much. Okay, so let's do 1 or 2 more questions. So what more the MOH needs to approve self-injection of DMP in Ethiopia? So because there are some good evidences from both global and regional evidences, what more do we need to do to have self-injectable DMP in Ethiopia at the moment? Nazanet, may I forward this one to you?
Oh, okay. Yes, like you said, Dr. Farid, we have good evidence globally, and also we have a pilot study from SI and its partners, and they have also a policy brief. And the key findings are almost similar to that of the global recommendations, but the DMP is not it's not provided as part of a choice in the National Family Planning Guideline. So if it's not in the National Family Planning Guideline, it will be difficult to procure, to forecast it annually and distribute to the health facilities. So even though we have a good recommendations, but it's not provided as part of the choice as one of the options in the National Family Planning Guideline. And also we don't have actually reports or research findings from different settings, because the finding we have is done in urban settings here in Addis Ababa. So we didn't have the data from the pastoralists, from the agrarian in the rest of the country. So we have to have research evidences from the rest of the country, and we have also have it in as an option in the National Family Planning Guideline. But we proceed accordingly.
Yeah, thank you for this update. I think it has been something the healthcare providers were very much interested to see this move into actual practice, but there are obvious limitations in having that pilot evidence and having that evidence disseminated to the larger community of health workers will be very important. I think we can take one more question before we finish. Any questions that you would like to address from the list? So from my end, what seems to be very interesting is how self-management of medical abortion can lead to missed opportunity for contraception provision. Yeah, you're muted, Mekdes. Probably,
Okay.
I know you are eager to do this. Okay, go ahead.
Actually, like for self-management of abortion, we are not going to miss for post-abortion contraception. The first thing is like in post-abortion period, almost all contraceptions are, we can say, they are safe and can be started right away unless otherwise there's some kind of complication to that. The other thing is except copper IOD, and yes, for injectables in our case, then the woman can resource or procure those contraceptions along with the abortion medications. So we need to work around it. Otherwise, I don't think like it will create a barrier for post-abortion contraception. The same is true for like counseling for post-abortion contraception, information like making informed decision on post-abortion contraception. So those can be delivered like in different platforms, not only like with health worker. That's why one of like even injectables are now being being self-injectable. So I think it won't create that much of a decrement in post-abortion contraception take up if we, uptake if we think about it ahead, like before implementing self-management of medical abortion.
Yeah, I think to add on more on that, on Dr. Nazana's points earlier, is at least in Ethiopian setting, the self-care of medical abortion is at least the eligibility will have to be done in a healthcare facility where the individual seeking care will have the opportunity to meet with a healthcare provider. I think that's where that contraception counseling and discussion and eligibility assessment will also be done. So I don't think self-management of medical abortion will silo the contraception initiation or uptake. So it will be part of the package of care that will be provided during a healthcare visit. So I don't think it will have an impact on that. Okay, Dr. Nazanat, anything that you want to add? A last word?
No, I don't have anything, but thank you.
Okay. Mekdes, do you have anything to say? Last, final?
No, thank you very much for SPIRHR and for creating this platform in self-care.
Yeah.
I'm happy to participate.
Okay. Again, I would like to thank all the participants today. I know there are many questions that we have not addressed. It's a bit overwhelming to have all these questions, but for the sake of time, we have to wind up our session. Again, I'd like to express my deep gratitude for Dr. Mekdes and Dr. Nazanat for joining us this afternoon. I know that the weather is very terrible, but we managed to pull off this webinar, and all the participants. So there is a question from the participants. If we could make this webinar available, yes, this webinar will be available on YouTube page of SPIRHR. So you, in a matter of a few days, so you can log into, you can just browse St. Paul Institute for Reproductive Health and Right, and you will get a YouTube link, and you can access all the materials in this webinar online. So having this said, we will have to wind up our session. Thank you for all participating. Thank you all for the presenters for taking your time, and thank you. And and again, it will also be available on the e-learning platform. So if you have missed it, you can just log into the e-learning platform and go through the videos and get your CEU. Thank you very much. Have a good day and see you on our next webinar.
Thank you.